So we take this conversations in this, and I would like to first invite our moderator of the session, the co-founder of Ayushman Bharat Conclave, Dr. Bobby John, to please join us. He also leads the Equitas Consulting. This is a consulting firm which is focused on the health policies. He's also the editor of the Journal of Development Policies and Practices. Our eminent speakers of the session would like to invite Mr. Varun Jhaveri, who's coordinating with the states. He's monitoring projects, liaising with the various stakeholders. He's from Ayushman Bharat NHA. And as we understand, as we heard from Dr. Indubhushan, that various states have signed the MOU. Certain states are yet to sign MOU. Certain states have said they don't want to sign. So how will that work, and how the states who have not signed, what will be, how the people in that state will benefit? We'll like to know from him. Inviting Dr. Rakesh Kumar Srivastava, the former DGHS Government of India. He brings in again, being the former DGHS, Director General Health Services, a lot of experience, expertise in the healthcare sector. So the best guide we can get from him. Dr. Shankar Prasad, the chairperson of Health Insurance Board, Nepal. This is, ladies and gentlemen, a newly formed board in Nepal in 2017, and which was formed by an act of parliament in the government of Nepal. He's the first chairperson, and as I understand, they have a similar kind of an insurance scheme, of course not of that scale, but it will be good to learn from them how they are implementing it. Our next speaker, Professor Dennis J. Streveler, from the University of Hawaii, the former regional advisor, WHO. And WHO, as we all know, as an international development agency, they have been working with an array of partners. They have been especially working with the developing world in helping the countries, providing them technical assistance so that the countries can achieve the universal health coverage targets. So having him here as an international development agency representative, WHO, who's doing great work with the government of India also, thanking him. So with that, we start the session. I hand over to Dr. Bobby John as the moderator of the session.
So good morning, everyone, once again, and welcome back to a series of discussions that we'll have for the rest of the day. The inaugural is done. The big headline numbers that Dr. Indubhushan put out on his slides are with us in our minds. We have heard from Tim Kelsey about the need to look at how we utilize newer technologies to be able to track what we are doing and ensure the quality of the outcomes. And then when we now, after tea, hopefully all of you have had a good cup of tea, coffee, or whatever it is, and you're refreshed back to some serious conversations and work. And if I may ask the organizers, can you just let the light in the room go up for a minute, please? Because for those of you that have attended IHW Foundation's events in the past, whether it's the India Health and Wellness Summit or the CSR Health Summit, or even now, one of the things that we strive to do is engage with the audience. You are not listeners. You are not an audience that's going to listen to the talking heads and the wise people here. My job is to make sure that the wise people, the experts, the panelists here are speaking to you, and you're also talking to them or you're engaging with them. So therefore, with a little bit more light, let me start with the audience here, and I'll set this pattern right in the beginning. Also mindful that there are 5 men sitting here on this panel. It is a shame that it's 5 men. There should have been 3 women here. And I will periodically keep reminding us that till we get equal balance on conversations up here as well as in the audience, we will not really have a meaningful conversation around health outcomes. Because frankly, folks, 50% of health, 50% of humanity is the other gender, which is not here on this stage at this point in time. Not for the lack of our trying, but we need to do a lot more better, and we want to acknowledge that as the IHW Foundation too, that we'll continue to strive to seek that balance here. Just in case somebody puts up there on the social media as yet another Manil. That's my disclaimer, that's my mea culpa, and that's the explanation why we have people here. Thank you very much for joining us. So, audience, we've heard the big slides. Even before they open their mouths, our gentlemen here, what are your questions for them? The session is about global and local impacts of doing something like Ayushman Bharat. And what are the questions that come to your mind? Is there a global impact? What is a local impact? How would you measure it? What's your question like? I want to assemble at least 2 or 3 questions or more, package that then back to then ask the panelists how they are responding and see how this conversation goes. And even though we've started a couple of minutes late, I promise that we will finish on time. So, without wasting time, who's got his hand up first? Sir, if you can introduce yourself and your question. Not a statement, just a question.
Hello. I'm Dr. Katuch. I'm from Gangaram Hospital.
Sir.
My question is for Mr. Jhaveri. If private hospitals are to meaningfully engage in geographical area like Delhi or a union territory which has not gone into a MOU with the central government, how would we do so?
Right, so the engagement of private hospitals is a question, and I'm not going to direct it to, don't direct it to any individual person, please, just direct it to me and I'll kind of try and feed it out. The lady, please.
Very good morning. I'm Ranjita Sood from Abbott, and I won't direct my question, but as we all know that Ayushman Bharat has 2 components, and both the components are not talking with each other. So how Government of India is going to implement the scheme effectively?
Fair enough. There are 2 parts to the Ayushman Bharat. How do they talk to each other? Great, sir. Yeah, go ahead. You've got the mic there.
Hi, sir. I am Dr. Ikram. I am representing an organization named as MedAccess Healthcare, which is a partner of implementation of this Ayushman Bharat scheme at the
Question,
ground.
please, question.
So, question is that because it's initial stage, very few private hospitals is part of this Ayushman Bharat scheme.
Nearly 15,000, 77% of them are private hospitals. Okay, go ahead.
But it's spread across country. Okay. So maybe I think number will be less than 10%. So as you, is a USP of the scheme, the packages are very, very strict and very on the lower budget side. So majority of the private sector still had not boarded on the scheme. Yeah. So what they see, this is a market distortion because we are implementation.
Okay. Is there a market distortion there? I'm going to take that question. So here, one last one here. And I'll come back another round. Yes, go ahead.
Yeah, Dr. Sarjit Jodeja. I used to work in AIMS and Ayush department and other institution. So I want to emphasize about this Indian system of medicine. Yeah, why not to impress the rest of the world our Indian system of medicine, which is alternative medicine, is a head.
Thank you.
Food itself. Yeah.
Right. So if I'm kind of gathering them together into my head and then trying to get this conversation going here. One is about how do we engage with private sector? It's not nearly enough. How do we ensure the health and wellness centers talk to the insurance side of the scheme? And how do we leverage our age-old wisdom in our Indian systems or indigenous systems of medicine? Now, locally, some things need to be done, and then we will pull it out into globally beyond our borders. We have the chair of the Nepal Health Insurance Board here with us. We have Professor Dennis all the way from Hawaii with us. He's worked in what, nearly 80 countries? 83 countries, and some of us have led the National Health Program here. The former Director General of Health Services, now the Senior Advisor with Wish Foundation, Dr. Srivastava is with us. And Mr. Jhaveri, let's start with you. Where is this conversation, or this process leading us? We've seen an impressive rollout, 155th day today? 157th day. This is one program that's tracking it and putting metrics on a daily basis on the evening. I can see the CEO of the NHA put out his tweets, so many numbers done, etc. You still hear that people are saying that it's not getting fast enough, far enough, deep enough. What's the solution? How are you going? What's your roadmap? Just press the button, please. Yes, thank you.
Check. Well, if I envision this country of 135 crore citizens, having a perfect scheme launched and anticipating that it's going to be the most smoothest implementation only in like around 5 months, I think that's a utopian world that we are living in. I think what we have expected and what we have accepted is the fact that it's a good start. And I think it's too early for Ayushman Bharat and everyone in the ecosystem to actually start gauging the impact. That what is the type of impact that Ayushman Bharat is fostering. I think probably what needs to be done and what we are doing is that we are trying to track the outcomes. We are trying to track. We have some of the important KPIs that you mentioned that CEO NHA keeps tracking on an everyday basis. So our particular emphasis is on the fact that we want to track the outcomes, we want to track the progress, we want to track the performance till the very lowest level. So whether it's at the hospital level or whether it's a district level, the entire progress is getting tracked. Now, what is that leading to is that we are trying to understand, which are the gray spots, which are the areas which require more focus, how are the greenfield states performing, how are the brownfield states performing, which regions has, the highest e-card generation, where do we see some particular data which is very encouraging, where do we see, some areas where we need, more pressure, where we need more capacity building. So all these things is getting tracked at a daily level. So I think what we have tried to do here is that we have tried to put a lot of emphasis on transparency and a lot of emphasis on accountability. So not only are we tracking data for us, but we are also publishing the data. We just don't want to keep the data with ourselves. We want to show to the country that how the scheme is performing. Now, I'm sure that CEO NHA spoke at length about the progress, but just to re-emphasize on the fact that in last 5 months, more than 13 lakh people, somewhere around 13 lakh 52,000 beneficiaries have already received free treatment under Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And I think that's a huge number.
Fair enough. So let me halt you there. You're saying 20 lakh, sorry, give me that number once again.
More than 13 lakh 50,000.
13 lakh 50,000 people.
Beneficiaries.
So that's 1.35 million people have been benefited in the last 157 days.
Exactly.
Right? Okay, so let's hold that there because we're talking about impact here. And till the number arrived, you were telling us about how we are getting to those numbers, right? So at this point in time, with a denominator of 1.35 billion people, 1.35 million seems to be a very impressive number, but a very small one to the scale, right? And then too, the question comes along, so what have this absorption been, the quality of that absorption been, what has it been absorbed for? Before I ask you to respond to that, and while you're ruminating on that, let me ask Dr. Srivastava. You've been part of the system for the last nearly 35 years before you kind of stepped out. You're part of the building up of the health systems in the public space. When you see something like the NHA come along, both in the, and the component of the health and wellness centers come along, how far is it now in the acceleration phase from the things that we've done before to actually begin to become impactful at family levels, individual levels, community, and at the subnational, national levels?
I think it will be inappropriate if we look at this insurance in isolation.
It's inappropriate if we look at this insurance in isolation.
Now it is part of the overall strategy of health, which is enshrined in the definition of health itself.
Right.
And as an old public health administrator in the government system, I know fully well that when we coin a program and allocate some fund for it, then these programs usually have got a tendency to create a shell around it and start acting in isolation. So this is what is happening at present.
So you mean a boundary of budget gets created?
Yes, it is the larger money, the bigger program, the stronger is the shell. So actually Ayushman Bharat has got two components. And somebody has said that these two components are not talking.
Right.
One component is health and wellness center, and the other component is this insurance system. Now, when the CEO presented the report card, it was as per KPI, the numbers, but not as in accordance to the OKR. At the end of the day, the strategic planning which has been put up in this particular scheme was going to result or was planned to go into creating a healthy human resource, less disease, by adopting all preventive, promotive, curative, and rehabilitative measures. And of all these, there was only small component which was requiring hospitalization and care. And that too, a hospitalization which need to be phased out close to the primary health care, secondary health care, and then tertiary health care. The total focus and the total 150 days report card shows the number of the hospital which has been empaneled, the number of the patients who have got the benefit by hospitalization, and the outcomes which is related to the quality. The other aspects, the linkage, say, Ayushman Mitra is sitting in a private hospital.
So let me hold you there. We'll come to the Ayushman Mitra and the thing there. But just to kind of pointedly ask this question, so we're talking about outcomes here. And you've very rightly mentioned that the report card is many, the KPI, the performance metrics, the operational parts of it. There was another number there, which was in the presentation. 60 million people who flirt with poverty simply because of catastrophic health insurances on a regular basis, health expenses on a regular basis. So isn't that also one of the outcomes that then we also need to be tracking, which earlier we didn't. We were thinking in terms of our health indicators and less about the poverty ones. And here, for the first time, we are trying to also track that together. So isn't that, to be fair, something that the NHA is kind of brought to the front?
I was just coming to that.
Yes, sir.
Exactly why I have spoken the word Ayushman Mitra was actually in relation to the 60 million population which is repeatedly going for hospitalization, may get a cashless hospitalization, may get treated. So I was talking to Ayushman Mitra in that relation.
Yes, sir.
At the end of the day, the patient comes from a community. And the first referral post for the community, as enshrined in the overall doctrine of this particular Ayushman Bharat, is Health and Wellness Center.
Right.
Now, why I said the word of Ayushman Bharat? Because Ayushman Bharat is not connected with a constituency of his own. Ayushman Bharat is connected with the hospital. He is not responsible priority-wise to a constituency, say, a cluster of 5 primary health centers. The primary client will belong to this particular Ayushman Bharat, which has got a network, operational network of these numbers of the hospitals. And this is the main reason that there is a disconnect between the health and wellness center. There is a disconnect between the preventive, promotive component of the healthcare, which is as important for preventing the 60 million population to go into the repeated cycle of hospitalization and going back. So that is exactly what I...
Absolutely fair point, and we'll table that for coming back on another round, because what you're pointing out to is the gentleman's question also. There are 2 components to it. There's a health and wellness component to it. Can it be better done so that we do not eat up, A, the provisions of the NHA 5 lakh per family per year, and also ensure that there is sustained health outcomes by doing some things in the preventive, promotive space. So we will table that for a moment. But let me ask Professor Streveler. India is doing all of this, and everybody kind of says this is a massive program that's happening. There's an old saying, if a tree falls in a forest, and nobody's seen it falling, does it make a noise, right? India is doing all of this. Is this making a epidemiological or a health impact noise for the global scenario?
Absolutely. Let me begin by congratulating India. Yes, maybe the number is small still, but yes, it's having an enormous impact because it's changing all of our minds. As we watch you from afar, we wonder whether, in fact, the world's best health insurance might actually one day be in India. You could be the model for the world. There's no question in my mind. We can find a way. Let me give some parameters of that. Of course, one of them is universal health coverage. We'll need to expand the number of beneficiaries. There's no question. We'll need to integrate the various stakeholders, whether they be the health and wellness centers with the payer, the AIMS and the tertiary healthcare with the rest of the public sector, the private sector with the public sector. All of those links and partnerships need to be formed to work together to create perhaps the best healthcare system in the world. This country has the potential for doing that. I happen to be an IT person. I come from a medical informatics background. We do think that the expressions this morning given by the leaders that digital health might in fact be the great lever and the great key to improving health in the world, we believe that. And we're hoping that with the IT tradition that India has, that you will become a leader in pushing that around. The other thing we need, however, is a common language. So if we're going to have health and wellness centers speaking to district hospitals, let's say, and we're going to have a good referral system between them, we need to have a set of standards by which that communication occurs. We all come from places where we have multiple natural languages. In my case, the indigenous languages in Hawaii have only recently kind of become amalgamated. And so the analogy in healthcare is the same. The computers need to speak to each other so that we can do the business together. Now, how does this happen? One final point.
Yeah, sure.
Excuse me, one final point. We need an equilibrium between the different stakeholders. It's not that the providers become less powerful and the payer becomes more powerful. No, that's the wrong scale. The scale of equilibrium is the right scale, that both sides have power. One is not beset by the other. They are partners. Of course, they're natural competitors because one wants to charge as much as possible. That's normal. If I buy a carpet in Turkey, it's the same. The carpet salesman wants me to pay the most. I don't know what that amount is. It's too much. As a buyer, I'll say that's too much, right? And so we have to have a negotiation of equals. And then we arrive at a price that's fair and a price that incentivizes the best health care by the provider. Because if we push them too much, they'll cut costs and we won't get quality. So we have to find that balance. So those are some of the elements.
Yeah, so therefore I'll take the last bit and then put it right up front. I mean, it's not an equilibrium between a provider and a payer alone. Right. There's a payer, whoever that may be, and there's a provider who wants to get as much from the payer side. But there's a third angle to this, the people. The ones who actually are the beneficiaries of what the payer provides and what the provider is committed to providing for that amount of resources. In the equilibrium that is being sought between the provider and the payer, is the beneficiary sometimes at risk? And that's something that I would like to ask the Nepal Health Insurance Board, newly set up board, the new chairman. I mean, where do you kind of draw inspiration from and how do you prioritize your patient outcomes rather than figuring out how it's going to do things with either the provider or with your system? Are you, like Dennis said, inspired by the Indian NHA system, or are you kind of thinking that, no, maybe we need to walk away and do something else? What's your perspective?
Thank you. Regarding the health insurance system in Nepal, so in 2015, we got national insurance policy. 2017, we got Act, National Health Insurance Act, and after that, program was launched in Nepal. And we have now 77 districts. Out of that, we have covered 39 districts right now. Regarding the total number of coverage in Nepal, we have only 15% of total population. So this is why coverage is less. Regarding that, it is not linked with only the insurance system. It is highly linked with quality health services at the service provider levels. So in Nepali system, what is happening, we have two types of system. One is first treatment point, and this is only for the government hospitals. And for the private hospitals, we have been regarded as referral centers. Those treatments are not available at the government hospitals. They are referred to the private hospitals. So once you see we have been facing the problem in Nepal. The major problem is availability of medicine 24 hours. Most of the health facilities of the government system, we don't have 24 hours pharmacy facility. So people go there and they cannot get the medicine at time. One thing is there. And quality service for equipments or human resources, all these matters are very, very important. So just we cannot link the health insurance system is highly linked with the holistic approach of the mechanism. So unless and until we increase the quality of the public hospitals particularly, it is very difficult to cover the whole system in the
right, let me hold you there, because you're saying something very, very important and something for us to hear probably from our neighbor, that this is a problem. One is, of course, your 15% coverage, but you're linking that directly to not the presence of an insurance board or the insurance mechanism, but to the actual quality of the service availability and also its steadiness of availability. To both Mr. Jhaveri and to Dr. Srivastava, what Nepal is pointing to, how are we beginning to address that? Both the ubiquity of service and the continuity of service, which then allows for people to come on the, if you're promoting the demand side, as I said earlier on, we can't promote something that is not there. So how do you kind of go about doing that?
You know, the scheme of Ayushman Bharat is something which has got a component of continuum of service. And that continuum of service is the only reason for having a system of empowered, rejuvenated health and wellness center. From there, the things start, and ultimately through the public health system, it goes to the hospitals. The second most important thing which it has got is a total health risk and disease pooling, and total resource pooling of private and the public health systems, and trying to bridge the gap with the help of finances which is being provided through a digital system of this insurance which we are talking. So as such, within the overall plan of Ayushman Bharat, there is a continuum of care which is enshrined over there. This is a fact. It has not been addressed very properly. And if it is not addressed very properly, then it will be resulting in probably underutilization of the facilities which are already in existence in the government system, and overburdening the private sector for hospitalization, resulting in over expenditure, and then may have an impact on continuity of such type of.
Ms. Jhaveri.
So it's a very valid point by all my fellow speakers. You know, when we talk about PMJ, I think you know, there are three vital components that that we are looking at long term. One is increasing the access to the healthcare. Second is increasing the affordability of healthcare. And third and one of the most vital is definitely increasing the quality of the healthcare that we are affording. You know, although this is a scheme which ensures financial protection, I think we have put a lot of emphasis and a lot of focus on ensuring that the quality of the healthcare which is delivered, it increases significantly. Now, now what we are doing for that is, first of all, we are having performance/quality-based incentives. So, if we have a particular hospital or a particular medical provider which is accredited with NABH, then we have a performance-based incentive. That is, we add a certain percentage of the base package rate that we are giving to that particular medical care provider over the top of the fixed package rate. Now, what we think is that these performance-based incentives are the incentives which is going to promote quality. At the same time, we are starting to hold a lot of consultations. We are starting to understand that, what are the type of best global parameters, considering the quality discussion which is going on across the world, that we can adopt to, and then we can incentivize, all the medical care providers. So, although we are talking, mostly about access and affordability, in the mainstream, quality remains a very strong backbone for our discussion. And the other thing is that, we have been telling, from day one that, this is not something which is like a perfect model or, we have achieved an equilibrium and then we have launched. But what we are saying is that we are ready and we stand committed to achieve that equilibrium. And that equilibrium can be in terms of access, affordability, and quality. And the other thing is that, we want to learn from other global systems. Sure. We want to learn from other quality models. Someone like Dr. Dennis, who has worked in 83 countries, we stand ready to learn from them, because we are a developing country and we are working at such a huge scale. This is the world's largest financial healthcare program. So, what we have said is that this is not probably the most optimum model, but we are ready to make it most optimum.
Dennis, what would be your takeaway if we are to kind of go, if we kind of keep building the linkages between the preventive side, the health and wellness promotive side, and then keep doing the supply side tightening while pushing the pull of the services? Where do you think we are all kind of
I think I'll answer this question with one word. We need an equilibrium between supply and demand. Okay, so if you have too much demand and no supply, you have a problem, a big problem. And if you have too much demand and no supply, you have also a big problem. There's a famous study in Netherlands where they shipped 10 more surgeons out to one of the districts past Amsterdam. And all of a sudden, the surgery rate tripled. Well, why? Because there was too much supply. There was no demand, but there was too much supply. And so the tonsillectomy profile went up like huge amount. So we have to keep, I think that's the one word I would use. I think we're in growing pains with PMJ, of course. It's a toddler yet. And but we don't spank it when it falls to the ground. We encourage it. We say, hey, you're beginning to waddle at least, right? And please forgive me if I'm not meaning to patronize. We have a long way to go to be a UHC for India. But there's no reason you can't get there if we keep the interests of every stakeholder in mind and we respect them. Every private concern, every NGO, every public concern, your large institutions like AIMS, the smallest PHC in the village, we have to integrate those services into a bigger whole.
Thank you. At 12:30, we are out of time. So here's my quick summary. The time went away, just like that, right? Here's my quick summary. The word that we are trying to look, or the way we kind of wanted this conversation to go was, is there local and global impact here? Well, sure, there is promise of local and global impact. There's a lot of stuff that's happening. It's only 157 days, but there's a lot of oomph behind this. The political will, the messaging is definitely there. It has put healthcare center stage into the political discourse too, if I may dare say so. And that's a good thing. So in that sense, yes, there is an impact. For the first time, people will begin to talk about health in electoral politics too. If that is an impact, I'm very happy, right? Beyond that, how do we actually begin to look at people's lives being better, that they're not slipping into poverty, will become a function of the equilibrium, Dennis, as you say, of the people that are supplying and of the people that are paying, being mindful of the people that actually are being impacted. Their lives are the ones that we are trying to change or improve. And so keeping in mind that. But keep focusing on what Dr. Shankar pointed out, that it does not matter how much you provide as an assurance of insurance or the ability to pay, if your quality of service or if your first treatment point does not exist, or if that's weak, the point that was amplified by Dr. Srivastava too, if that health and wellness supply side does not function to its designed effectiveness, then we either push too many people up or we simply have very poor utilization. And so therefore the promise of impact, both at India levels, definitely there, and if India does, 1/6 of humanity does something, there'll be a global impact, but that is a potential impact. It is yet to be realized, even though we are off to a good start. I couldn't come back to you for any more questions, but I hope the one question that remains unanswered, and I'll try and skin that somewhere later during the day, is what do we do with our traditional systems of medicine and health and wellness, and how do we kind of see that figure in our entire programmatic framework? That I will come back to. We're completely out of time on this panel. Thank you very much for being with us, and thank you for your questions right up front. A round of applause for them, please. Thank you so much.
Yeah, thank you to our panelists. Just on the little bit of knowledge or information which I have, wanted to share, as there was a talk like the wellness centers or the health and the wellness centers, the two components are not talking. But we already have the Government of India scheme, the ICDS, the Nutrition Mission, Poshan Abhiyan. They are working. They are working on the ground. They are working with the people towards nutrition, which was something which was spoken out, the preventive aspect. So that is also being taken care. When we talk about these two components, the preventive aspect, the curative, of course, comes more from the PMJ, but the health centers are going to be taking care of the preventive and the promotive part. That is what I understand.
Which will be our last session.
Yeah, so.
Yeah. Thank you. Sure, it's work in progress, and that's why I wanted to leave.
Okay.
Okay. Sure.
So thank you to all our panelists, and I would like to request and invite Mr. Kamal to kindly present the mementos, thanking each one of our eminent speakers, sharing their experience with us, sharing the work with us, which shows that yes, work or impact is happening at the global as well as the local level, and that comes very assuring, especially as was spoken Thank you.